Good afternoon and good evening, everyone. I am Alessandro Repici, gastroenterologist in Milano. I want to give you a warm welcome on behalf of the ESGE and the ESGE Governing Board. I'm very pleased to have all of you for this amazing session dedicated to endoscopic treatment of Zenkers Diverticulum. Endoscopic treatment has become probably the first option for many of patients with the Zenkers Diverticulum. This is why there is a lot to discuss, a lot to learn from two super experts. We have the privilege tonight, this afternoon, to have Dr. Sandra Nagl from Augsburg, Germany, and Professor Jan Martinek from Czech Republic. They will deal with the different options that we have when we meet a Zenkers Diverticulum. We need to decide how to treat it. And I think it's time to start. And again, I want to thank ESGE and for giving me the opportunity to moderate this session. I want to invite Professor Jan Martinek to start with the presentation.
Thank you, Alessandro, for your kind introduction. My topic is to cover Z-poem for Zenkers Diverticulum. Here's my disclosure. And I would like firstly to introduce the disease. So Zenkers Diverticulum is a herniation of the mucosa and submucosa. So there's no muscle layer in the posterior wall of the hypopharynx or upper esophagus in a site called Killian's triangle. And this site is between the cricopharyngeal muscle and the lower constrictor muscle. And we can see at the image the typical endoscopic view of Zenkers Diverticulum. Please note that they're in the same area, but at the anterior side, there could also be rare Killian-Jamiason diverticulum. So there are two options at the side to have two diverticulums, but the Zenker always at the posterior side. It's rather not very frequent disease, male predominance, and usually we see patients having age between 70 to 80 years, but there are exceptions, or there are some patients with a younger age presenting with Zenkers Diverticulum. Symptoms include dysphagia, burping, chronic cough and regurgitation, halitosis. If there is a problem with food intake, patients may experience weight loss or may suffer from aspiration pneumonias. What about the diagnostics? The key for diagnosis is endoscopy and X-ray. On X-ray, you can see the sac on the posterior side of the esophagus. The size of the diverticulum may vary between few millimeters till centimeters. And please note that each endoscopist, especially young endoscopists, should introduce the scope in every patient carefully, because every patient undergoing gastroscopy may potentially have a Zenkers Diverticulum. If the introduction is not careful, the scope might enter the diverticulum and make perforated. There is no need for standard manometry or flip examination in patients with Zenker. What about the treatment? The ESGE guidelines published in 2020 recommended as a first-line treatment flexible endoscopic approach for both Zenkers Diverticulum as a first treatment, or even for recurrent Zenkers Diverticulum. But at that time, the flexible endoscopic approach, because I was part of the group publishing this guideline, we consider as a flexible endoscopic approach this traditional septotomie, which will be covered by Sandra later this evening. Z-poem in 2020 was considered as an experimental therapy, and Z-poem was recommended to be performed only within clinical trials. Today, in 2024, I think the situation has changed, and ZPOM may be considered as a standard endoscopic approach. To describe the technique, here is a Zenkers Diverticulum. It's a mid-sized diverticulum. Usually we inject just above the septum, and we perform an incision alongside the septum. This is the mucosal incision, and you will appreciate in a few moments the septum, which is a muscle. And the aim of ZPOM is to create first two tunnels. The first one is between the septum, which is a cricopharyngeal and esophageal muscle, and the esophageal mucosa. And as you see, this is the submucosa between the septum and the esophagus. And we are creating, by using spray coag, the first tunnel. Once the tunnel is ready, there is a need to do a second tunnel between diverticulum and the septum. So in contrast to POEM, where we do one tunnel, in a Zenkers Diverticulum for ZPOM, we perform two tunnels. And the first tunnel in the esophagus, we may go all the way down to the cardia. Here at the divertical site, we just finish once we don't see any space, any submucosa. Once two tunnels are created, we can start myotomy, which we perform perpendicular like this, and we can appreciate the muscle fibers. And the muscle has two parts. This is the esophageal part, which can be theoretically cut all the way down to the cardia. And on the other side is the cricopharyngeal part, or divertical muscle, which will end up, and the aim is to cut the complete cricopharyngeal muscle, like you can see here. There is no need to cut the esophageal muscle to the cardia. I think I cut it usually to the same level as the cricopharyngeal muscle. At the first look, this muscle looks as a one mass, but always these muscles split into two. At the end, we can clip the incision, which is quite easy if we perform incision above the septum. Here you see the older version of ZPOM, because the first ZPOM were performed 5-6 years ago, and the procedure started by incision in hypopharynx, so 2 centimeters above the septum, and clipping or closure was really very challenging. So nowadays, I think all endoscopists performing ZPOM, they do the incision above the septum. Here you can also see technique of myotomy. Usually I use the spray coag or endocut mode, and all type of knives can be used, the dual knife, TT knife, hook knife. It's up to the endoscopist. This is the end, and you can imagine that closure of this hole was much more difficult compared to the first one. One among the first studies published in 2020 showed that ZPOM is very successful, clinical success 92%, technical success almost 100%, but the procedure time was 52 minutes, quite a long procedure, but I think it was because it was a new procedure and the endoscopists were not too experienced to perform ZPOM. What is important in my view is really size of the diverticulum, because we have a small diverticulus till 2 centimeters, mid-sized diverticulus, and large diverticulus. And here you see the problem in a small diverticulus, because to perform traditional septotomy in small diverticulus like here, which is less than 1 centimeter, it's almost impossible, or we can do only partial septotomy. And in my view, for small diverticulus, ZPOM is a method of the first choice. This is the case. You see the incision this muscle was quite spastic, so the incision was not easy, and I should have started maybe a little bit more on the right side, but nevertheless, you can also see the procedures which are challenging. And always when we do ZPOM, we should use the transparent cap on the tip of the scope. In a few seconds, just then we succeeded to enter the submucosal space, and we were able to perform the first tunnel between the septum and the esophagus. Again, theoretically, you can go all the way down along to the cardia. And here we will do the second tunnel, which will be rather short because the septum is short. And you can appreciate really the nice view that you control each millimeter of your endoscopy. So dissecting the submucosa. And once both tunnels are ready, I will show you the myotomy of this short septum or diverticulum. And the advantage of this procedure of ZPOM is that we can really perform a complete myotomy of a cricopharyngeal muscle. So this is the esophageal part going left, and here on the left you will see the diverticular side, the cricopharyngeal muscle, which will be cut just in a few seconds. Yeah, now I'm going to cut the cricopharyngeal muscle, and you can cut till disappearance of the muscle fibers, which is now the cricopharyngeal muscle disappeared, and this is the esophageal muscle. And at the end, we close the incision by using clips, which again, if you do the incision as I showed you, it's relatively easy. I like to use a Lokkaido clip because they have the short end of the clips, so in case of need, you don't have problems with other clips which have a longer ending. And in 3 months, this is the same patient describing 150% improvement, and in fact, no diverticulum or no residual diverticulum visible. Alessandro published in 2020 the study describing ZPOM in patients with small diverticula, technical success 100%, and you see the Alessandro very good endoscopist, mean procedure time 14 minutes compared to 50 minutes in the study I showed you before, clinical success rate 25%, and no adverse events and no recurrent up to the 12 months of the follow-up. What about the large diverticulum? Because if you imagine ZPOM in patients with large diverticula, and if only muscle is dissected, so the pouch sac is unchanged, and it can create the pseudo-diverticulum. So the pouch can cause the problems like the diverticulum. Usually patients describe improvement, but there can be some residual symptoms. There are 2 ways how to overcome this problem in patients with larger diverticula. First is to complete the ZPOM with the mucosal flap incision, as shown in this paper, or there is another technique, which is the video from our hospital, but firstly described by Mu and Kashyap. And please know that this procedure is experimental and should be done within clinical trials. It's called open ZPOM. We see again the patient with Zenker diverticulum. The usual technique, creating 2 tunnels and then myotomy. And After completing myotomy, you see now, after completing myotomy, we perform the mucosal flap incision. So we cut the mucosa. But in contrast to standard ZPOM, after cutting the mucosa, this is the divertical side. And on the other side is the esophageal part, still cutting the muscle a little bit more and mucosa. And at the end, we don't use clips, we don't close the wound, we leave it as it is. We just put the hemostatic gel, and that is. And we have done few open ZPOMs, and in my view, the advantage could really be that there is no 0% of residual diverticulum. The swallowing on X-ray is smooth, and it's an interesting approach, but please note we keep patients 2 days in the hospital because of security. We give 2 days antibiotics, and again, it's experimental approach. ZPOM is done under general anesthesia with CO2 insufflation. We use a transparent distal cap, and we use a single dose of antibiotics in patients with standard ZPOM and double dose of antibiotics after open ZPOM. Is ZPOM better or worse than septotomy? We don't know. And I do hope that next year we will see the results, the complete results of a randomized trial, ZIPIT trial. The principal investigator is Michal Kaminsky, comparing septotomy with ZPOM. And I choose this meta-analysis just comparing septotomy and ZPOM. And if you look at the technical success 96, clinical success 93, adverse events 12%, and recurrence after ZPOM 11%, these numbers and also these plots, these two methods look rather similar. What about the ZPOM in patients with recurrent diverticulum? So this is the patient with a recurrent Zenker diverticulum after traditional septotomy, and because of fibrosis, it's usually impossible to perform 2 tunnels. So this is the modification. The video comes from Michal Kaminsky department. So he performed, or he creates only 1 tunnel on the esophageal side, and then he cut the septum, as you can appreciate here, by using dual knife. And this is modified ZPOM with a single tunnel septotomy. So Zenker diverticulum is kind of game, and we can play up or down, or we can modify the techniques, and ZPOM has some different modifications, and Sandra will also show some modification of traditional septotomy. So in conclusion, ZPOM is an emerging procedure which should be considered as standard, but I would like to underline that ZPOM should be performed by endoscopists who are experienced in third space endoscopy or have a proper training in third space endoscopy. If not, traditional septotomy is a method of choice. At present, no clear advantage over standard septotomy approach has been demonstrated for ZPOM. ZPOM, in my view, is a method of choice for small diverticulums. ZPOM is effective even for recurrent diverticulum, and open ZPOM is an experimental approach and should be performed only within clinical trials. Thank you for your attention.
Thank you very much. I think it was very extensive, and the session is open for a few questions. Jan, may I get started with a few questions for you?
Yes.
So what is your practice for ZPOM? Is patients undergoing a general anesthesia or deep sedation?
I usually choose, especially in an older patient, general anesthesia, because the risk of aspiration is lower. But there are exceptions. For example, in high-risk patients, we can also do Zenkers under propofol analogous sedation, especially if the procedure is quick. Nevertheless, 85% I do under general anesthesia.
Okay, so once the treatment is done, what is the way you manage the patients afterwards? So when they get some food or liquids, if you keep the patients into the hospital, how you follow up the patients there, are you using antibiotics? Can you please give us some practical?
So for ZPOM, the patients are given antibiotics just before the procedure, not after, with the exception of open ZPOM, as I underlined that we at the present time, if we do open ZPOM, we administer antibiotics before the procedure and POD 1, post-operative day 1. But standard ZPOM with a clip closure, we administer one single shot of antibiotics, ceftriaxone and metronidazole before the procedure. We keep the patients one night in the hospital, nothing per mouth. It means no food, no drinks, and infusions. The following day, we don't check any X-ray. If the clip closure we feel was safe and the patients start drinking, and the next day, which is usually at home, they start eating the mashed potatoes or the yeah, exactly. And so we don't do ZPOM as an outpatient procedure, not only because of the security, but also because of reimbursement, because the Zenker treatment is in our country reimbursed only if the patients are kept overnight.
Okay, interesting. Okay, Sandra, do you have any other point to discuss with Jan? Because Jan has a flight to be taken, so it's a little bit under time pressure.
Yes, I think maybe there are also some questions from the chat regarding the most common complications for ZPOM and how to deal with that, how to manage them.
Yeah, to be honest, we performed several ZPOMs, quite a lot, even for the ZIPIT trial. I have not yet experienced any complication compared to septotomie, where I experienced some perforations, or especially when using the diverticuloscope. So the most common complication I cannot say, because the bleeding, which can occur during the procedure, usually is stopped during the procedure and should not be considered as a complication. We never had any infectious complication, any perforation. So in my view, like other third space procedures, it seems that the procedure is very safe. And there is also the question from Greece, Konstantina, is the position of the patient supine or left-right important? To me, is not an issue. If the patient is intubated, is a supine position, which is majority of cases I explained to you. And in case we perform the quick treatment under propofol analogous sedation, of course the patient is on left-right position, left lateral position.
Okay, Jan, thank you so much. Very extensive, beautiful videos, I would say. They were very didactic. We learned a lot. So feel free to go to take your flight, and we move on with Dr. Sandra Nagl, and she will talk about the more traditional approach to Zenkers Diverticulum. Sandra, the floor is yours.
Yeah, thank you very much for the kind introduction, Alessandro. And so we heard now about ZPOM, which is quite a new procedure in the armamentarium of treatment options for Zenkers Diverticulum. But when we go a step back, then we know that historically Zenkers Diverticulum is treated with surgical diverticulotomy performed either through an open surgery or using a rigid endoscope. But given the technical issues related to restricted neck mobility and the invasiveness of surgical treatment, endoscopic treatment techniques such as flexible endoscopic septum division have come more and more into the focus in the last years. And in the next slides, I will mainly focus on the flexible endoscopic septum division. So flexible endoscopic septum division was first described in 1995 and essentially involves the myotomy of the diverticular septum, meaning that we perform an incision of the mucosa and also the muscle fibers. So in this example, for example, we see a quite large diverticulum in entry. We see the septum, and here really a narrow entrance into the esophageal lumen. And the technique of flexible endoscopic septum division aims to cut the cricopharyngeal muscle in order to create a single pouch between the diverticulum and the esophageal lumen. And the standard flexible endoscopic septum division is performed with the patient in the left lateral position. It can be performed in deep sedation, so there's no need for general anesthesia. And usually we also use an overtube to improve the septum exposure, and also that also helps to stabilize our position, endoscopic position, towards the septum. And once you have a nice exposure of the septum, then you can start with the incision of the mucosa and then cut your way through along the midline of the cricopharyngeal muscle in a 90-degree angle to the septum muscle. This is so the central approach to cut the mucosa and the cricopharyngeal muscle in the midline is the most used technique. And then when you continue cutting, you reach the bottom of the diverticula. And while you cut, you can identify the two parts of the cricopharyngeal muscle, the esophageal part and the diverticular part. And by cutting in the central part of the diverticula, you create a kind of V-shaped cutting line. And when you then withdraw your overtube, then you see or can identify the single pouch between the diverticulum and the esophageal lumen. So flexible endoscopic septum division was first published in 1995 and has shown an overall 93% persistent relief from dysphagia during a mean follow-up of 36 months, with an overall very low adverse events rate of less than 5%, which were all managed conservatively. And when we look at a large meta-analysis, including 813 patients, the overall pooled success rate was 91%, with a recurrence rate of about 11%. And then overall, the technique is considered to be very safe, with mostly only mild adverse events of 11%. So that's why the ESGE guidelines from 2020 suggest flexible endoscopic treatment over the surgical treatment as the first-line treatment for Zenkers Diverticulum when they are symptomatic of any size. You can enhance the technique either using a cap to stabilize the position of the scope and to have a better distance and overview to the septum. Then usually you also can use a nasal or orogastric tube or a guide wire, which you place into the esophageal lumen as a landmark during the septotomie. And this enhances the safety of the procedure by ensuring an accurate identification and protection of the esophageal wall. Or instead of a cap assistance, you can use a so-called overtube, which improves the septum exposure and stabilizes the position of your scope and provides some kind of aspiration protection. So the overtube is beak-shaped with two soft lips at its tips, and these soft lips have two different lengths. And the shorter lip is placed in the diverticula and the longer lip in the esophageal lumen. And there's also a black mark on the overtubers, marking approximately the level of the patient's row of teeth up to which the overtube should be advanced into the patient. And the overtube is advanced over the endoscope using the endoscope as guiding rail. And then when you introduce the overtubers into the patient, make sure that the longer lip of the overtube is oriented downwards during the insertion. And then the overtube is advanced with small control movements until you feel some resistance. And this is usually the time when the black line of your overtube is at the row of the patient's teeth. And then you slowly withdraw your scope from the stomach, and then you find the longer lip of the overtube in the esophageal lumen with a nice exposure of the septum just in between the two lips of the overtube. This gives you a really stable position. Here at the 12 o'clock position, you have the entrance into the esophagus. At the 6 o'clock position, the entrance into the esophagus. And why is this important? Because when you compare the use of a cap assistance versus the use of an overtube with this technique, then also this has been a retrospective study with a small number of patients. But anyway, the use of overtube has shown to be associated with a higher clinical success, a lower recurrence rate, a faster procedure time, and an adverse events of 0% compared to 32% when you use a cap. Flexible endoscopic septum division can also be performed with different instruments. You can use the needle knife, you can use argon plasma coagulation, ESD knives such as hook knife, dual knife, IT knife, or a stack beetle knife, which is a scissor-like instruments. And overall, in the literature, we find with all these instruments a high clinical success rate ranging about 80 to 100%. But these are predominantly retrospective and single center studies, and the variations in the instruments and as well inconsistence about the use of an overtube or cap or a nasogastric tube makes comparisons between the different techniques and different instruments difficult. So we learned about the traditional flexible endoscopic septum incision, meaning that we perform a single incision in the central part of the septum, which creates a kind of V-shape cutting line. But there's also variations of this technique, for example, the double incision and snare resection technique, meaning that we perform two incisions, one about 1 centimeter apart from the other, and then the central part of the septum is resected by a snare, and this creates a U shape of cutting line, which has a greater exposure of the muscle fibers in order to really get to the bottom of the diverticulum. So this is the technique I routinely perform at our center, the double incision snare resection technique. I use the stack beetle knife, which is a scissor-like instrument. You can rotate it in a 36-degree position, and you can really grasp the mucosa and the muscle fibers in a really controlled manner by pulling the muscle fibers towards you, so to decrease the risk of perforation, and you can coagulate and cut at the same time, which decreases the risk of immediate bleeding. So for the double incision and snare resection technique, you start at one side of the septum, and you perform a myotomy of the cricopharyngeal muscle until a depth of about one centimeter, and then you start a second incision just 1 centimeter left of your initial incision, and you cut through the muscle fibers in a really controlled manner, and until you reach about the same level of incision depth, and then the central part of the septum is then cut with the snare. And this allows that you have a greater exposure of muscle fibers. You can here nicely identify the esophageal part and the diverticular part of the cricopharyngeal muscle. And then you can continue either by cutting in a double incision way or just continuing in a central incision way, and cut your way through until you reach the bottom of the diverticulum. And you do not cut only the muscle fiber, but you also cut the mucosal flap immediately. And once you're close to the bottom of the diverticular, you can withdraw a little bit your overtube just to ensure that, or to see if there are any muscle fibers left, and then you can really cut all the remaining muscle fibers. So this technique has been published in 2018, showing an overall very high clinical success rate of 94% with a low recurrence rate, and only 2 minor bleedings during the procedures were documented. The question is, when we perform flexible endoscopic septotomie, is always how deep should we cut, because from a pathophysiological aspect, it makes sense to really cut all the muscle fibers of the cricopharyngeal muscle. And but also the technique of flexible endoscopic septotomie allows you to reach the bottom of the diverticular. When you withdraw a little bit the overtube, you can identify remaining muscle fibers, and here in this example, you see that we really reached the bottom, and there are no remaining muscle fibers left. There's only one part from the esophageal part. Then the next thing is, should we clip when we performed flexible endoscopic septomy? Well, there is no data or not sufficient evidence supporting that clipping has any beneficial effect in terms of post-procedural adverse events. But I personally always put at least one clip in the central part of after the resection, just to adapt a little bit the resection wound. There's no need to completely close your resection wound. Just 1 or 2 clips is completely sufficient. So we heard about Septotomie from Jan, we heard about flexible endoscopic septotomie, and we also heard about some hybrid techniques which might help to overcome the limitations of both techniques, and help to complete or have the benefits of both procedures. And one hybrid technique is, for example, as Jan already mentioned, the Septotomie with mucosal flap incision. And another hybrid technique is a tunneling-free parallel endoscopic septotomie, meaning that you start a mucosal incision, then you inject on both sides of the septum, the submucosal space, but you do not perform a submucosal tunneling. You just use it as a cushion during the myotomy of the cricopharyngeal muscle. Then I think an important point to consider is what should we do when patient has a relapse of his symptoms after he has already been treated. And there are some predictors of symptom relapse within 48 months of endoscopic therapy. These are really large endoscopic, really large Zenker diverticulum, such as greater than 5 centimeters, or Zenker diverticulum greater than 10 millimeters after the treatment, or if the length of the septotomie was less than 25 millimeters. But anyway, from the ESGE guidelines from 2020, they suggest the treatment to be done by flexible endoscopic septotomie for recurrent Zenkers diverticulum. And this is also based on study where they showed that after retreatment, this leads to an equal symptom relief as compared to a successful first-line treatment. And even after a second, third, or fourth session of flexible endoscopic septotomy, it is not associated with a higher rate of adverse events. So when we try to compare SEPTOM, flexible endoscopic septotomy, what should we consider for our patients? For now, we can only rely on retrospective studies. We are still awaiting results from a randomized trial, as Jan already mentioned. But when we look at this retrospective multicenter study, which is quite a huge one, which compared rigid versus flexible approach versus SEPTOM, they show that there is no difference in terms of technical success, clinical success, and symptom recurrence, but there was a huge difference in terms of adverse events. Rigid approach was associated with the highest adverse events, followed by SEPTOM, and flexible endoscopic septotomy was only associated with 2.3% of adverse events. So finally, to conclude, I try to highlight the advantages and limitations of these procedures we heard of from. So starting with flexible endoscopic septotomy, one main advantage is that we can perform it in deep sedation. We have a shorter procedure time, so usually this procedure takes me like 10 to 15 minutes in average. It is very safe with the use of an overtubulus, and even for recurrent Zenkers Diverticulum, we can perform these procedures 2, 3, 4 times without an increase of adverse events. But as Jan already mentioned, it might be difficult, especially for Zenker Diverticulum less than 1 centimeter in size. On the other hand, SEPTOM might have its place, especially for these small Zenker Diverticulums. But on the other hand, it requires usually general anesthesia. It has a longer procedure time. It is technically more demanding and especially challenging in pre-treated diverticular, and therefore potentially associated with higher adverse events. And then we have these hybrid techniques, which combine the benefits of both procedures and try to overcome the limitations of both procedures. So potentially we can perform them in deep sedation. They have shorter procedure time when compared to SEPTOM, but maybe they are still technically more demanding compared to flexible endoscopic septotomy, but maybe less than SEPTOM. So my conclusion, and that is my personal one, but I think also based on the available literature so far. So whenever we have a pre-treated Zenker Diverticulum, I think flexible endoscopic septotomy is still the treatment of choice. If you have a naive one, then it really depends on the size. I think flexible endoscopic septotomy is still the gold standard for larger diverticulum, and SEPTOM or POES might have their place for septoms less than 1 centimeter, but I think flexible endoscopic septotomy is still feasible also in these small ones. Thank you.
Thank you, Sandra. So very nice. And what I also love, very balanced conclusions. So since Jan moved, I will give you a couple of questions. The first is, when you talk about recurrence, you are also including patients with recurrent symptoms or recurrent pouch after surgical treatment?
You mean after, yes, about recurrence. So the endoscopic treatment is also possible after failed surgical treatment. So there's actually, we just performed several of them with a really great success and without increased risk of adverse events.
And do you see any contraindication to endoscopic treatment for patients with a Zenker?
Contraindications. I mean, the flexible endoscopic septotomy is really a very safe procedure. So normally we have a very old collective of patients with potentially are not capable for general anesthesia. So the advantage of the flexible one is you just can perform with deep sedation with the use of the overtubulus. You have an aspiration protection. So in my opinion, actually, there's
No, basically.
inpatient. Yes.
Yeah. And do you sort of agree with the initial Jan recommendation that basically all small size diverticula should be treated with a tunneling and a longer myotomy because it's the only way to prevent a high rate of recurrence?
Mm-hmm. Well, I agree with Jan that Septotomie should only be performed by endoscopists really experienced insert space endoscopy. I think this is the prerequisite. Otherwise, I think this is a method which is highly associated with adverse events when you're not experienced. Small diverticuli, especially with a really strong septum, with a broad septum, and with a less extent, like less than 1 centimeter, can be really challenging in treatment, especially when they are asymmetric. So in these cases, it might be difficult to get a stable position using the overtures. In this case, yes, Septotomie might be beneficial. If it is the standard approach, yeah, we will see. We will need more data, I think, on that.
Fine, I'm agree with that. So my final question. So what is your approach? Closure or not closure? Clipping or not clipping? What you suggest?
For the flexible endoscopic septomy, I always place like at least 1 clip, but usually just 1 clip at the bottom of the diverticular base, just in the central part, just to get a kind of adaptation. I had once the case that the patient was coughing afterwards, and then we had a spontaneous dissection of the esophageal wall. The patient was completely stable clinically, but on the X-ray afterwards, the Zenker was greater than on the pre-treated version, and that so we performed an endoscopy on the following day, seeing that there was a spontaneous dissection, and since then I always place 1 clip to adapt the wound resection area.
Okay, Sandra, very extensive. Congratulations, beautiful presentation. I think we are going to the end. I would like to thank all the people who stayed with us for this webinar. We touched several points of Zenkers Diverticulum treatment. Also, I want to thank the ESGE team that supported us for this webinar. They always they do a wonderful job. Very thankful to them. And I think now we have a couple of slides I have to share with you. So the first one, the most important endoscopy event in the world is by far the ESGE days. So we want to remind all of you that we have a abstract deadline, also a little bit extended the deadline for those who are members of ESGE. We also pay a lot of attention, ESGE pay a lot of attention to the young endoscopists. So there is the next generation award that we invite all these young folk being part of ESGE and being in love with endoscopy to apply for the award. And we wait for all of you next year at the ESGE days. And also there is the ESGE Academy, because also we want to allow people a very safe journey in training in advanced endoscopy. And I think the ESGE Academy is the ideal place for people who want to start their career or want to improve the way they do endoscopy. So please also consider ESGE Academy as a potential option for you to improve your practice in endoscopy. And I think we have a final slides. We love having the young face of endoscopy next to us. So join ESGE, become members for the young generation. There is a huge amount of benefits that they can get. And of course, having this young generation is going to enrich so much the society and the global village of endoscopy. So please join us. Thank you so much.